In our first panel, we heard from patients, real stories, real frustration, but also real hope. We heard what happens when the system fails, and we heard what happens when it works. But now we turn to our expert panel to examine the three priorities the patients raised and to ask a simple, direct question. What can actually be done? This is the Global CRSwNP Awareness Day Expert Panel Debate. Well, I promised you an expert panel, and let me say it doesn't come more expert than this. Joining me from London, Professor Glenis Scadding. She is an allergologist with decades of experience at the intersection of allergy, rhinitis, and asthma. She brings a perspective that is essential to this conversation because CRSwNP does not exist in a vacuum. Joining her, Dr. Sven Schneider. He is an ENT specialist from Austria with deep expertise in the mechanisms of CRSwNP and what the future of treatment looks like. Joining them, Dr. An-Sofie Viskens. She is an ENT resident from Belgium. She's starting out in her career, and crucially, she brings a fresh perspective on how the next generation of specialists is being trained to deal with this condition. Mrs. Lana Hannant is a respiratory nurse from the United Kingdom who works in secondary care and sees firsthand what happens when patients move or fail to move between pulmonology and ENT. And last, but by no means least, of course, Mrs. Tonya Winders. She is CEO of the Global Allergy and Asthma Patient Platform, or GAAPP, and she joins us from the United States to bring the policy and advocacy perspective. A very warm welcome to all of you. Well, I'm going to go back and stick to those three priorities we identified in our first debate with the patients. These were, remember, firstly, getting to the right diagnosis faster. Secondly, understanding your conditions and options. And thirdly, knowing when to take action. So let's start with priority one, getting to the right diagnosis faster. I'm going to start with you, if I may, Sven. Dr. Schneider, let's start with the basics, because not everyone watching this will know this. What exactly is CRSwNP, or Nasal Polyp Syndrome? What drives it? And also, from a clinical standpoint, why does it sometimes take so long to identify it?
Well, CRS with nasal polyps, or CRS like chronic rhinosinusitis, is a chronic inflammation of the nose, of the nasal mucosa, and of the mucosa in the paranasal sinuses. And if the mucosa in the nose is swollen, it produces a lot of secretion, it blocks the air because of the edema, polyps can occur, and sense of smell gets lost. So if you have any of those symptoms, there is something wrong with the sinuses. What the patient needs to know is actually that if there's anything wrong, anything blocked, this can change over time. So if the symptoms are like weak to moderate in the beginning, this can get worse over time. And so it's quite important to report those symptoms to your physician and make up the whole picture for the physician, what the symptoms are. Don't leave anything out.
Yeah, I mean, it was quite interesting, actually, talking to all the patients, that actually many people think it's not that debilitating, it's a minor condition. That is not what the patient said.
Well, maybe sometimes it's a minor condition even for the patient in the beginning, but usually it gets worse over time. And symptoms of the sinusitis can be like very broad. It can not only affect the nose, but it can also affect, for example, the mood. Yeah, you can get frustrated, you can get embarrassed, you can get sometimes like even depressive-like disorders. And also it can affect the sleep. So this is a very broad range of symptoms that can be caused by an airway disease, by a sinusitis.
Fantastic, thank you. Professor Scadding, we know each other very well. I've interviewed you many times indeed. Look, you sit at a really interesting crossroads as far as I can see as an allergologist, because you see patients with allergic rhinitis, with asthma, conditions that also overlap, connect with CRSwNP. So how often do you find undiagnosed nasal polyps in your patients, I suppose, is the first question. And also, what does that link between upper airways disease and lower airways disease actually look like in practice?
About 20 to 60% of patients with rhinitis have asthma, and it's higher with rhinosinusitis, which is what we're talking about today. And the link varies. If you're talking about young children, they will often start with allergic rhinitis and progress to allergic asthma. With adults, they probably start with upper airway disease, frequently mild, and then develop polyps and later asthma, and possibly later aspirin sensitivity. So these are different patterns of disease in different ages.
So the presentation can vary quite significantly?
Absolutely, yeah.
And so one of the other things we talked about was that, and particularly with Catherine earlier, we talked about a lot of the time, the GPs may not know a great deal about CRSwNP.
That's absolutely true. If they've had ENT training, they will know. But if they haven't, then they'll know very little about it. And the general public don't really understand the nose. They think the nose is two little tubes going up like this.
Yeah, they do.
In fact, it goes halfway back into your head. So we need to educate the general public and their general practitioners.
Yeah, and also one of the other things we talked about in that first debate was the way that upper airway conditions are deprioritized compared with lower airways disease. And that seems to be true across the board. So I suppose the question is, what can allergologists do, ENT physicians, and also pulmonologists genuinely do between them to come together to address that?
One is to have mixed clinics. I've worked in a clinic with an ENT surgeon for most of my adult working life, and it has been a revelation to me most weeks, and I think a revelation to her as well. We've taught each other a lot, and we've done well by our patients by looking at the whole patient, a whole respiratory tract at one go, and looking for comorbidities.
So this whole thing about actually continuing professional development of physicians and nurses, I think is absolutely paramount. I'm going to bring you in, if I may, Lana, here, because you work on the front line here. You're a respiratory nurse in secondary care, so you see patients with asthma and also other lower airways conditions every day. How much do nurses know, do you think? I'm going to put you on the spot, actually, slightly there.
I do, and I'm embarrassed to admit I haven't known anything about the condition until I've come across and been invited to the meeting, and when I've heard the patients' stories. So yes, very little, and I lead the team, and I've never trained my team. I always say think outside of the box, but that outside of the box never been, knows symptoms that relate to that.
So again, what we're seeing here is actually it's about the training of doctors and nurses and also being aware of that condition. When you see these patients, what sort of questions do you ask when you're trying to work out what's going on in the upper airways? What would you normally say?
I would only ask the question of the patient that I can visibly see or hear that they're having an issue with nose, so they may be a bit more congested. My question would be, do you suffer with nasal congestion? How often is it affecting you? Is there any other symptoms? Patients never volunteer. When you ask about respiratory symptoms, they never volunteer upper airways issues. They do not see themselves as a respiratory issue. Therefore,
because it's in their head.
It is in their head, so they do not see it. They do not volunteer it. I would only ask when I actually can visibly see that there is an issue.
Glenis?
If only we could get everybody treating asthma to ask two questions.
Right.
One, can you breathe through your nose? Two, have you got a sense of smell? And they would pick up most of the CRS with NP patients with those two questions.
So if it's that simple, Sven, why are we not doing that?
I don't know. I'm trying to spread the message. Yeah, exactly those two questions. Whenever I'm talking to pulmonologists or GPs, those two questions help a lot. If those two questions are answered by yes, I have a problem with my breathing, or yes, I don't feel I can smell like I used to, then look in the nose is recommended strongly.
And Lana, back to you, just in terms of practical challenges, obviously one of the other things we heard was the way that patients seem to be passed from doctor to doctor, they're referred on, things are missed. What is the biggest challenge you see in your clinical practice?
The lack of pathway. You know, if I could ask those two questions and I know where I go and what I ask, as a respiratory nurse, I will describe the respiratory symptoms. I do not really know how to sell to ENT to say, actually, this patient desperately needs to see you. Yes, I would make a referral if I feel it's appropriate.
Let me bring you in, Dr. Viskens, if I may. The patients pretty much across the board actually made a really important point earlier, which is diagnostic delay doesn't just happen in primary care, it seems to happen in specialist settings as well. So you, when you were training, how much attention did CRSwNP get in your ENT residency program? Was there a lot or a little?
I'm of course biased because my PhD was on it, but when I noticed my colleagues, they do know what it is. They also do know the schedule of it, the treatment schedule, definitely there. However, when we are on the rhinology consultations, then we think about it. But I think we also need to be more aware of it in other consultations. For example, as Sven mentioned earlier, sometimes patients have trouble sleeping. And sometimes we see patients on the sleep apnea clinic that also have nasal polyps. We do not think about it then, but it's really important to also do a proper examination there of the nose to see if there is anything troubling them and to really think with a broad diagnosis and also there think about CRS with nasal polyps.
So we mentioned earlier about the gap in knowledge for those physicians, if I'm being kind, who trained a while ago, that maybe they're not aware of CRSwNP. But in terms of the new generation of specialists coming through like yourself, are they being trained appropriately?
I do think so. I do think that we are being trained appropriately and that we also are also thinking more about the lower airways. When we see a patient that gets referred to us with symptoms of CRS, we see is it CRS with or without nasal polyps, and also we do question them about any lower airway symptoms so that we can get a consultation with the pulmonologist so that we can work better together, which I see is happening more often now with the new treatment options being there.
So it sounds encouraging. I'm going to bring you in, if I may, Tonya. What are your thoughts hearing this, that actually there seems to be gaps in knowledge, not just in primary care, in secondary care? It depends whether the physician or the nurse knows about these conditions. It seems very sporadic and very patchy, and so therefore the patient outcome will differ depending on which clinician they see.
Absolutely. And I think that the reality for many people living with this condition is that they adapt, they normalize. This just is the way they've always had trouble breathing. They don't even realize that perhaps their congestion is getting worse, or perhaps they've lost that complete sense of smell or taste, even more so. And so again, we as human beings tend to do this, right? We sort of normalize, adapt, and carry on. And so it is, I think, incumbent on the patient to be attuned to their body and to bring up those conversations, regardless of what setting they're in, with either the respiratory nurse, the GP, or the specialist.
Yeah, tricky though sometimes, because of course patients think, well, I don't want to bother the clinician with time, for example. Am I actually asking the right question, for example?
Yes, and just being aware that something has changed, right? And that there may be new treatment options. I think, again, it's very important that the science has evolved in this specific disease area pretty rapidly over the last 5 to 10 years. And so if you've been living with that stuffy nose or with the inability to fully sleep through the night and breathe appropriately, smell appropriately, then it really is time to revisit your provider and have a new conversation.
Very sage words indeed. Thank you very much indeed, everyone. Right, let's move on to our second priority now. That's understanding your condition and your options. Let's go back to the panel, to Sven, to Dr. Schneider. Now, our patients told us they often leave appointments, I dare say, without really understanding their condition. Is it something you recognize? Or I'm sure your consultations are amazing, but would you normally, do you think that's fair, actually, that patients are often sort of shepherded out of the door and maybe they don't really understand?
I hope I'm not like this, honestly, and I take my time. But yeah, maybe this can happen. And there's a lot of questions that need to be asked and need to be answered and also the doctor has to get the feeling in which situation the patient is, because some patients are really experts in their field. They had 4 surgeries, whatever, medications before, and they really inform themselves, but some have no idea about what's going on, and then you need time and need to explain what it is, what the disease means, how the disease can progress, maybe what the cause of or we don't even sometimes know the cause, but what can trigger the disease, and yeah, it takes some time, and I hope we can train the colleagues better to give the right information in the maybe right amount of time, and also the patients to ask the right questions and get their information. And like the patient portal, get additional information for the patients where they can inform themselves easily.
And that's a really good point. We spoke about that earlier on, actually. The fact is you're constrained by the consultation time. You can't possibly explain everything in that time, and the patient portal obviously was developed to fill that gap. Dr. Viskens, if I may come to you from a clinical standpoint as well, how do you see tools like this, the patient portal, fitting into that consultation? Just carrying on from what Sven said there, is that something that you will say to patients, right, I've given you the information that I can possibly give you, go to this patient portal because it will help you?
Yes, I do that often on my consultation, because I do think that you give patients a lot of information on the consultation. Sometimes you see that they try to get it, but they're really not getting it, and you only have so much time left. Then I say, like, it's a lot of information for today. This is a really good portal. Take your time, and when I see you next time and you have some questions still, then we can go further, follow up into that. But I really think that's also the future, to bring patients to those portals to get the right information to the patient at the right time.
Professor Scadding, I just want to pick up on that as well. We talked a great deal about patient education, and one thing that came up really strongly, I think, from the patients was the need to connect all of those dots, talking about CRSwNP, not in the silo, but actually alongside allergy, for example, other airways diseases. I keep going back to the fact you have a really unique vantage point here, because you've seen it and you can see it in a broad spectrum across the board. How would you try to translate that for patients? What should patients kind of understand?
First of all, they need to understand that the respiratory tract starts here and then goes right down to your lungs. So that if they've just got a diagnosis of asthma, they should think about their nose.
So when you say that to the patient, are they shocked?
Yeah.
I think they are.
They are.
Yeah.
They are. It's amazing how people don't think about the upper and the lower airway being linked and being functional in one unit. And vice versa, if they've got nasal disease, they should always think about their chest, and their physician should ask them about it. But also, they shouldn't forget about things like their ears, which are frequently affected, their sleep, and of course, poor sleep and sleep apnea leads to raised blood pressure, leads to heart problems. So this is a whole spectrum of diseases that we need to stop really early in its tracks. And we're now beginning to have the possibility of doing that.
I just want to go back to this patient portal now. So some diseases like allergic fungal rhinosinusitis are given even less attention. How do you think patients can use the patient portal to feel appreciated, informed, particularly on those things that maybe are rarer, that people don't see, clinicians may not know much about?
Yeah, that's a very good point. I talk about the 3 A's: allergic fungal sinusitis, anti-neutrophil cytoplasmic antibodies, and aspirin sensitivity. And they're all reasons why patients might do badly. I think the portal can enable those patients who are not doing well to have the confidence to go back and say, look, I'm not doing well. Have I got something underlying this that you can treat me for?
See, I love that. An informed patient going back, putting the clinician on the spot. I mean, that's very powerful. Let me come to you, Tonya, if I may. From a policy perspective, patient education, it's often acknowledged, we talk about it the whole time, let's make sure we have patient education, but actually, when it comes down to it, there isn't the cash. It's often not funded properly. What do you think it takes to convince policymakers? Because we know it's really important to stop bad outcomes.
So I think when speaking to policymakers, it really does come down to sort of three key components. We have to have the emotional stories, and we heard that from our patient advocates and experts earlier in our presentation. So having those emotional stories about the burden and the impact of the disease. And then we have to have the scientific evidence. We have to know, number one, how many people this is impacting. For example, about 4% of the general population. We also have to know what is the latest evidence-based approach to diagnosis, treatment, and long-term management, including education, and make sure that those are part of national respiratory strategies and plans to identify patients, to get the right treatment to the right person at the right time, and to support them and their caregivers along the journey. And then the final piece that we need in policymaker conversations are economics. So we know that in Nasal Polyp Syndrome, in CRSwNP, oftentimes patients spend upwards of 4,000 euros per year in managing their condition. That's their out-of-pocket cost. So having that conversation with a policymaker to say, again, this could save the system significantly, not only in the comorbidities that we've already heard about, but also in the direct out-of-pocket expense that patients are facing.
I mean, that's a staggering figure, actually. And given that, and in terms of policy, why then, given that everything you say is true, why doesn't it still have the presence that it should have, CRSwNP? Why is it not recognized? Why are they not saying, these are great points, we need to do something about it?
Well, I think we heard this again from our patient panel earlier. Most people are not going to die from this condition unless they have comorbid depression or another condition that threatens their cardiovascular system or their lung health. So I think that that's the reality. It doesn't often get that sort of attention because of the lack of mortality directly associated. I also think that unfortunately policymakers are weighing a lot of different issues, right? And trying to allocate budgets accordingly to those conditions that do have the greatest impact and burden on society. So that's why cancer, diabetes, and heart disease oftentimes rise to the top. But as we've heard, this condition can significantly impact heart health and lung health. And so we should not just overlook it.
Glenis, I can bring you in here. What's going wrong?
I think it's the division between the upper and lower airway is one problem. And that's why people like you don't think about the nose, because you're trained on just half the respiratory tract. And
So
the
it's
other
a failure
problem,
of training?
training, yeah.
Yeah.
The other problem, I think, is that the economic cost of this disease is not fully understood. And there's a paper from several years ago showing that upper airway disease is far more costly than things like hypertension, diabetes, and asthma combined, largely because of the effects on sleep. People who don't sleep well don't think well. They still go to work, but they don't work well. It's called presenteeism. Kids who have that problem go to school, and they don't do well in their GCSEs. And this is not really well known. We need to push it.
Yeah, really fascinating. Thank you very much indeed to you all. Let's now move to our third priority now. I'm going to come back to you, Tonya, if I may. In that first debate, the idea that people stop seeking care because they sort of accept their symptoms, oh, they're starting to getting worse, they may be normal. It sort of resonated with our panel. From your experience and your work with GAAPP, how common is this, that as the symptoms deteriorate, they don't really do anything about it?
Well, again, as I said before, we all normalize and adapt and sort of make excuses for one reason or another of why we may not be at the level of health that we once were. And this is common. And so I do think this is one area where especially the loved ones of that individual should step in and speak up. I was speaking with a caregiver earlier today, and she said, it's so frustrating because I love him and I want him to be healthy and well, and but I also don't want to completely frustrate him because of the lack of treatment options that have been available to this point. So I think it's important for that entire circle of influence, the patient, and their loved ones to really be informed about this condition and to seek the highest level of care needed to get the latest, greatest innovative treatment.
I mean, it's quite interesting, that relationship, isn't it, where there's a patient who is getting worse, but the other half doesn't want to nag them to say, you need to go back, you need to say, I need better care. That's a real problem, actually.
Absolutely, yeah.
Dr. Schneider, if I may, we have also heard the other side here. Patients who did go back, they then got the right treatment, whether that was surgery, a biologic, or whatever else. It found their lives did change as a result. So I suppose when treatment works, it works really, really well. What does that look like for you in terms of the patient journey? So what I'm saying is that we've heard about people sitting at home, their symptoms not doing well, but actually when they go back, if they're persistent, if they have knowledge, if they use the patient portal, you can see really different outcomes, can't you?
Mm-hmm. Yeah, well, we have new treatment options, and like every other year, there's a new treatment option available nowadays. So I think it's worth to ask the right questions and ask if there's any possibility for improvement if you don't feel well. Yeah.
And is this a passage of time? We've talked a lot about biologics. I spoke about the fact that certain countries didn't have biologics, the United Kingdom being one of those, that they were frustrated that they could read that these treatments were available in other countries, but not in their country. Is it a matter of just saying, is there anything new? Is, you know, what is the science evolving? Is that, I mean, I don't know how practical that is, actually. Professor Scadding, you recognise this, don't you? Because we've spoken about it before, where patients in the United Kingdom are saying, hang on a minute, why have they got it in Europe? We haven't got it here. Yeah. It seems deeply unfair. Now, obviously, I don't want to go into the metrics and the way that we evaluate drugs, but it is a problem.
It is a problem.
Just in terms of that, there's been a real push towards defining what controlled disease actually is, just making sure that we actually know what it looks like. Your comments and thoughts on that, and to make sure really that patients aim to have controlled disease.
Absolutely. We need a good CRS control test that takes into account all the facets of disease, but doesn't take too long to do. And EUFOREA is working on this very hard.
Sophie, let me just ask you, what does controlled disease look like to you?
All right. Definitely, I ask my patient, do you feel controlled? Because sometimes we ask...
Do they know what that means?
You have to give them certain symptoms, like, do you still feel like your quality of life at the moment is where you want it to be? Do you still feel that you can't smell very good, or that your nasal obstruction is still there or not? You get these key symptoms, you ask about them, and then you ask them, do you feel controlled at the moment with your symptoms on a scale to 10? And then it's, when it's below 3, then I do think they are controlled, or below 5, depending on which...
So you have metrics to define what controlled disease looks like.
Yes.
But do the patients have some sort of way that they understand that they are controlled? Are they very much at the mercy of whether you think they're controlled? What I'm trying to understand is, do they know when they're controlled?
Yeah, they will tell you. When they feel great, they feel controlled, they will definitely tell you. And as Professor Scadding said, they will almost embrace you.
Throw you around the room, as I heard from Glenis. Tonya.
Yes, I can't sit quietly on this topic. So at GAAPP, we have actually surveyed over 1,200 nasal polyp syndrome patients. And I think most of the time they really do overestimate that their level of control, because they don't realize that they have, number one, if someone is offering a second surgery, time out, stop, do not proceed without seeing an advanced specialist and having a conversation about alternative treatments. Number two, if you have repeat courses of oral steroids due to your nasal polyps, time out, stop, see a specialist, have a conversation. If you're having sleep awakening. So there are some really practical ways that we can help patients to identify what is a lack of control, because unfortunately, I think they're often overestimating that and really downplaying the burden that they have in their lives.
How interesting. And Lana, may I come back to you here? The role of the nurse, this is something I'm particularly interested in. As a nurse, you could argue you have more time with patients, hopefully, than many doctors do. Can the nurse play a bigger role here in trying to screen for uncontrolled airways diseases, playing a more central role in dealing with those patients who've got severe disease? You're a really important resource, I think, the nurse.
Absolutely agree. Yes, we do have much more time with patients. Patients tend to tell a bigger story to the nurses. I'm not sure what it is about us, but
Are they more truthful, do you think?
I think we hear much more. Absolutely, we do. Absolutely. And I suppose we can support patients and we can help with screening and actually taking patients to the right.
So just putting all of this together from what Tonya said, Professor Scadding said, from what Sven said, for example, what would help the nurse? If you have more time with the patients, and then you've got these, what I think are quite distinct criteria saying whether you're controlled or not, is that something that nurses could do to have more education? Absolutely. Would that be helpful?
Absolutely. Even those two questions, you know, can you breathe through your nose and can you smell? I mean, that's the basic check of patients, you know, day-to-day living. Absolutely.
And that's not being done currently? Dr. Schneider, let me just come back to you. In many other disease modalities, there is this concept of hitting hard and early, really hard and early. Would this be applicable here in CRSwNP?
If there are severe symptoms, if sense of smell is gone, I would go full in, all in.
But that's very dependent on what the patient is telling you.
Of course.
I see Professor Scadding grinning at me there. But again, it's also the patient knowing what good looks like.
Yes, absolutely. If you do a post-mortem, about 4% of the population have nasal polyps, but only about 2% of those are symptomatic. So you don't want to go operating on nasal polyps just because they're there. Absolutely right.
Right.
But if they're problematic, then apparently, from a UK study, the earlier you operate, the better. The outcomes are better if you operate early. And it's probably true of biologics as well, although we don't really have that evidence fully yet.
Tonya?
Yes, I am probably a more aggressive, proactive patient advocate to say go often, go early, and definitely aggressively manage this condition. Because I hear the stories day in, day out of the impact, of the heartbreak and the frustration of people. We heard it from our patient panel. When you can't smell, you can't taste. It impacts not only just, you know, the eating 3 times or more a day, but also your intimacy and other aspects of your life, right? Because those 2 senses are so very important to living a full life. So I think that is why I would say we have to be a bit more proactive and aggressive in our approach.
I'm just wondering how much of that is cultural as well. Is it cultural? I mean, I'm trying to not be rude here. Is it cultural? Is it an American thing?
I do think that what we see in advocacy is that in the West, including even Western Europe, there's a major difference between Western Europe and Eastern Europe in that empowerment and activation of the patient community. So there is a stronger, more aggressive Western approach to patient education, patient empowerment, and patient advocacy. But we're seeing that shift. Even in Asia Pacific, for example, we're seeing patients become much more demanding around the level of care, the information they receive, and leveling that playing field when it comes to treatment options, demanding that if something is approved in one portion of the world, it should be available globally.
Let's just talk about that as the global situation, the UN Declaration on Non-Communicable Diseases and the WHO Lung Resolution. How can they help with this? Is it important? What can they actually define that would help the global population?
So 2025 was a milestone year when it comes to respiratory health, lung health, and the one airway concept. With these 2 documents, we have the Integrated Lung Health Resolution at the World Health Assembly, calling on countries to actually have national respiratory plans and to think about this disease or the diseases and the burden of diseases from over the course of a lifetime with someone, you know, their lung health over the lifetime. That includes the nose as well, right, as we've heard. And the political declaration that was also passed last year, again, member states, countries are demanding that we recognize chronic respiratory disease and have more defined pathways for managing chronic respiratory disease because of the impact that we've already heard on how it impacts an entire person's life and well-being.
Really fascinating stuff. Thank you very much indeed to all of you for the moment. Now, we've got a few minutes to pull all of this together. What I want to do now is to get something really concrete from all of you. Now, we have discussed those 3 priorities today. Firstly, getting diagnosed faster. Secondly, understanding your condition. And thirdly, going back, we keep hearing this, going back when your disease is uncontrolled. But here's the challenge. What is your number 1 priority? What is the one thing you believe will make the biggest difference in, let's say, the next 12 months? I'm going to put you on the spot here. There is a rule, though. You cannot pick the same one that someone has already said, right? So you've got to choose carefully. So it's which priority and one concrete step which you need to implement that. Professor Scadding, you go first.
I would get every person treating asthma to ask those 2 questions about the nose.
That's very good. Dr. Schneider.
I'm for patient education. We're working on that. There is this Global Awareness Day. We're trying to do a part to educate the patients better.
Fine. Dr. Viskens?
I would focus on getting the patients that are not controlled back to the clinic, because there are new options now, and we need to also educate the patient about that, and it cannot happen if they do not come back to us.
It's getting harder now, Mrs. Lana.
I would ask those 2 questions.
You can't, you? Only Professor Scadding can do that one. You need a new one.
Implement asking those 2 questions. Well, I don't know. Is that not going to be that?
I'll let you off. Okay.
Thank you very much.
And Tonya, that leaves you in really the most difficult position. What's your recommendation?
So for me, I would say know your rights. As a patient living with CRSwNP, know your rights. Download the GAAPP patient charter, go to the patient portal on EUFOREA, learn about this condition, and learn about how to get timely, accurate diagnosis and a personalized treatment plan that you can live your best life.
Brilliant. Thank you very much indeed to all of you. 5 voices and 5 commitments. I want to hold all of you to those because you're on record. We recorded you. Thank you very much to my amazing panel, to Professor Glenis Scadding, to Dr. Sven Schneider, to Dr. An-Sofie Viskens, Mrs. Lana Hannant, and Mrs. Tonya Winders. Well, today has been about more than just awareness. It's been about identifying the exact moments in that patient journey when things go wrong and where they go wrong and how we commit to change them. But it has also been about what is possible. We heard from patients whose lives were transformed when they finally got the right care. And we heard these 3 priorities: get diagnosed sooner, understand your condition, and if your symptoms come back, then take action. So to every patient watching, your experience matters. Your voice is heard, and you deserve the best possible care. To every clinician, the tools are there, the treatments are improving, and the patients are counting on you. And to every policymaker, CRSwNP affects millions of people. It is time it got the attention it deserves. Well, if you feel inspired after these great panel discussions, now is the time to join EUFOREA and help shape the future of respiratory care. You can find more information about EUFOREA and also register for the EUFOREA educational events on the euforea.org website, where you can also sign up to receive the latest news via email. Also, we are on social media, oh yes, everywhere, on YouTube, X, LinkedIn, Spotify, Instagram, TikTok, and Facebook, literally everywhere. Please do follow us. Also, finally, these shows would not have been possible without our partners, so a very big thank you to our platinum partner, that's Sanofi Regeneron, and our silver partner, GSK. And all that remains for me to do is to thank our extraordinary panel here and the panel before that, and thank you for joining us for this year's Global CRSwNP, or Nasal Polyp Syndrome Awareness Day. From all of us here, goodbye.